right, let's make some tips. What tips can we give patients? So first of all, it all starts with positioning the patient. So when you position the patient, you've got to make sure that the props are low profile. So you don't want to have props which are sticking out, because when you do a hip, the robot comes from the opposite side. When you do a knee, the robot comes from the same side. So we started off with those props that stick out. We found that they would block the robot, so we wouldn't recommend those. Then we found that, we have to make sure that the prop at the front of the hip doesn't get into the way of where you're going to put the pins. So we recommend that you mark the iliac crest, which is what we're showing there, and then you feel the bone, and you put 3 or 4 dots where you're going to put the pins. And then you need to make sure that the prop at the front, if you're somebody assistant or positioning, doesn't go higher than the iliac crest. So we push that prop in, and we put padding in there, and we make sure that prop is positioned securely over the anterior spherical spine, but you have to be able to see the iliac crest. Now I mark higher up so that when you do the prep, they don't come near that area. Now for the hip, you have to put a reference point on the knee. So that reference point is an electrode which you reference off in order to work out your leg length. So we recommend that you've got to be careful where you put this electrode, because you have to put it on a firm point. So put it on the tubercle or put it on the actual patella. Do not put it on the tendon, because look what happens when you're referencing that with a probe. If it's on the tendon, see how it goes in. So that will give you a discrepancy in your leg length, because you're going to reference your leg length off that. So that's quite important. Now this is our scrub staff. You can see we've got a catheter bag on him, so he doesn't have to go for a break or coffee break. So anyway, we've got him positioned there. Make sure for the knees that you position him close to the side of the table. So he's got to be side of the table, because you don't want to position too flexed or too extended. You want to aim for a lazy 90 position. So positioning of the robot is something that you will develop and you will learn as you go through. When we started, the textbook positioning is that. The problem with the textbook positioning is that the camera falls in the same position as where the anaesthetist is. Now, if you've got an anaesthetist who's not in theatre wandering around, then you're all right. But if you've got an anaesthetist who wants to sit down, read the paper, then you've got to make sure that the camera system is put in a separate position. So what we found is that the camera position, so we're going to show you where we position things now. So for a hip, this is the layout that we have. The robot will come from the opposite side. So this is a right hip that we're doing. So Cole is setting up the robot there. This screen, which is the Mako station, which you should never touch unless you're the specialist, then can be faced towards the table. And then we've got the camera, which I keep on the side of the hip myself now, after about 50 cases of doing it the other way, which was much harder. That's where the anaesthetist chair is, and you can see the sets have been put out. So the sets are being put out, and you can have a look at those in the next video. So from the knee replacement point of view, the robot comes in on the side of the actual knee. So the patient's positioned on the table, and the robot will come in on the same side. And you can see the sets there. So they're all laid out. That's a sort of typical setup there. And then you can see the camera there, which is set up there. You can see somebody hiding there. So that's the setup that we use for a knee. Now, it took me a while to work this out. So we've got the same scrub nurse with his catheter bag on there. So it took me a while to work out, because this robotic arm will cut out if you extend it or if you hyperflex it. So you've got to keep the arm at 90 degrees. So the robotic arm has to be just over the knee. So for a few cases, what we found was the robot kept cutting out. So this elbow needs to be at 90 degrees in a position where it can make the cuts. If it's hyperextended or hyperflexed, it will cut out. So this is just demonstrating the robotic arm. It demonstrates the positions that are ideal in order for you to get the absolute best cutting. We pre-prep, so we prep everybody. So we have, while the nurses are preparing the robot, we've got pre-prepping going on. There's one of our scrub and staff, who's Louise, who's pre-prepping. So we prep very accurately. We do a proper full pre-prep in the anaesthetic room. So we take it seriously, they gown up, they do it properly, do the foot. So we reduce the risk of infection if we can. So this can be going on while you're setting up the robot. Then we've developed our own technique for draping the knee, because rather than using stockings and bulky equipment, we put a bit of iron at the bottom. We use a clear bag for the foot, and then we put an iron band on top. So the advantage for you is that you can see the knee, you can see the tibia, and you can feel the malleoli, so you can see everything. Most surgeons will put a stockinette on, put a crepe bandage on, and the problem is you can't reference through that accurately. So we're putting the drape on there, we're going to put that on top, and that seals the knee very nicely. I think it's quite an important tip because it allows you to reference the malleoli much more easier. So we put that on and we're able to do that. And you can see we put that down and we can feel the landmarks, we can feel the ankle. So we're pretty confident that when we're on the ankle joint, we know exactly where the medial and lateral malleolus is. So this is our hip draping, pretty standard, you'll see it. The important thing to note here is at the top of the hip, we've left space for where the pins go in. So we use two drapes. We use one underneath the hip, which is positioned on there. So some of you will drape like this, but the most important thing is that you need space at the top where you've marked the iliac crest and where the pins are going to go in. And then we put another drape on top of this. We make sure that the exposure is there in terms of the pins, because the worst thing you can do is drape the patient and then not be able to put the pins in. That's going to be a big problem for you because you're not going to be able to put the pins where they should go. And you need those pins to reference the patellar position. So that's pretty straightforward. So this is, I recommend using 11 blade to put the pins in, because with the 11 blade, you can actually feel that you're going down onto the bone. So we make the incisions on the actual bone. And with the 11 blade, don't use those big 23, 22 blades, don't make big incisions. 11 blade, feel the iliac crest. And this is really important because you need to make sure that you're on the bone. Because if you're not on the bone, that pin will go either into the abdomen or it will go outside the pelvis. And you can tell by feeling if you're in bone. So we put the first pin in, and then we feel the second pin and bounce it up and down on the actual iliac crest to make sure that it's on bone. And then you can drill that through. And then we've got your assistant will remove that. You can check the pelvis position by moving the pins. And then you put then you have the Mako ray, which is already set up. And that's been put in down onto the pelvis. For the hip, there's one ray. For the knee, there are two rays. And again, we put the third and final pin in. Now, it's very important at this point, you've got to make sure, and we usually get the SFAs, the assistants will do this, they'll rotate the rays so they're facing the camera. So these have to be detected by the camera, because once you've started, this position is set, you can't keep changing it. So that's your reference position. So we recommend put local anesthetic into the pins, because they can be uncomfortable. And then we tighten all those nuts there to make sure it's absolutely tight. You've got to make sure those nuts are tight. We've done, when we started, there were a couple of cases that they weren't tight and it caused errors, which then we had to sort of pinpoint the problem to, which was here. This is the setup during an operation. So you can see the rays are there. The rays have changed now. We can both put in the incision and you can see where the robotic arm will come in. So there's no jigs there. The arm will come in and it will do the surgery. It will cut the bone. So that's kind of the setup you've got for a knee operation. and that's demonstrating, there are no jigs now. So the important thing to remember is that when you're cutting the tibia, you rely on the tibial jig. When you cut the femur, you rely on the femoral jig, so you can cover the other jig. Whilst the pre-prepping is going on, we've got a system that we have 2 scrub nurses. We have one who's preparing the robot, so they will start to prepare the rays. And you have standard packs which come out, and then you've got the robotic ray, the main one that goes on the robot. Make sure these discs, these Visi discs, are down on the ray. It's a really important point, because if there's a small gap, even a millimeter gap is going to create an error when you're registering, when you're trying to get the accuracy, because you're trying to be accurate within a millimeter or less. So you have the robotic ray, and then you have, for the knee, there's a femoral array. And if you've got big hands, you can push down and they're all clicking. If you've got small hands, it doesn't matter. You can do them individually. But make sure those discs are clean. So during the operation, sometimes these discs get dirty. So you have to make sure they're wiped and they're clean, because if they're dirty, they're not recognized. So once you've done the femoral ray, then you end up with the tibial ray, which we're demonstrating here. The knee tibial ray is being put in. And then there's 4 discs on each of these which go on, and they're impacted down to a deep position. And then you've got a final ray, which is the knee end effector ray, which is used for calibration on the robot, and that has 4 discs on there. Now, there's 2 probes that are used during the operation. One is a blunt probe, which is a green probe, and one is a blue probe, which is a sharp probe. So they come pre-packed here. So the probes are taken out. So you can basically take the probes. Again, it's pretty well indicated on the box which position to put them in. So the rays go on. So when we started, this took a bit of time, but now they're done very quickly. So that's the sharp probe is the blue one. The blue one is used to map the bone. And these probes have 3 discs. So again, make sure that the discs are down and clear. So when you're doing all this while the your colleague is preparing the trays, so you've got all these ready, and that's your standard Mako setup. All these videos are available on a YouTube channel, which Jared can give you the details of. So if you want these videos, you can have those. We've got those. Now the setup is important, because what we found was that you've got to set up the tray. The tray has to be a reflection of your organization. So it's a bit like your kitchen at home. So if you've got things everywhere, it means your kitchen is messy at home. If you've got everything neat and tidy, it means that you're neat and tidy at home. So we would suggest that you set things up like this. At the bottom, there's a tray, which we have a tray where we have the pins in, we have the guides in there, we have some checkpoints in there, and we're going to go through this on the stations. But you have 2 long, there's 4mm pins, and there's 3.2mm pins. Now there has been a case where the 3.2mm pin has broken in the iliac crest. Not in our hospital, but there has been a case which has been reported. So we would recommend that you don't use those, use the 4mm pins. And then you have these checkpoints which are placed for referencing during the operation. They're small checkpoints. One is placed on the femur, and then one is placed on the tibia. You've got to be careful with these checkpoints, because when they started doing many years ago, Mako, even in centres like Exeter, there were cases reported where the checkpoints were left in. So we have a safety checklist which we put on the wall, or you can just make a note of it, to make sure at the end of the operation the checkpoints are out and the pins lengths are similar. So that's the setup on the table there. And then you'll be careful with the robot. Once that saw is very sharp, it's very rigid saw, so it's not flexible. So if the saw is not tucked in and the scrub nurse walks past, there is a risk that you could cut her neck. And one of our early cases, we nearly happened. We had a scrub person who walked past and it just missed her neck, unfortunately. A bit of a Freudian slip there. Anyway, she's still with us. She's still with us. She's got a bit of a crinkled neck, but she's still with us. We call her knick-knack. Right. Okay. So the robot draping. I'm not an expert in this because I don't normally do it, but the system they teach you to do it can be quite a complex system because you've got to cross your arms, do various things. But the faculty this afternoon will demonstrate to you how to do it with a simpler system. So you almost have to drape the robot reverse. So the MPS pulls the sterile cover over. You'll get two blue identifiers which will show you. One is where the tool will go on, the robotic saw will go on, and one is where the check raise will go on. So the registration, there'll be a station on that, which we'll do in the afternoon, which will show you the tips on how to register the robot. When we started, this process took a long time, but now this process is done while we're pre-prepping, while we're getting ready. So it's a quick automated process now. So you've got to make sure that the robot is covered with a sterile drape. A lot of people walk past the robot and some people will touch it and they won't be aware that they've touched it. So it becomes non-sterile. So always cover the MoCo robot with a sterile drape. Always check your checkpoints at the end and the length of those. And the saw blade needs to be sort of reached in so it's not able to. These saw blades are extremely sharp. They're very rigid saw blades, so they're not flexible. They're very rigid and they're very sharp. So there's a sequence on how you put the saw blades on. There's a small saw blade which can be used for smaller implants. You change the saw blades in the middle of the operation. We can show you how to do that. We've talked about the short pins and the long pins.